I want to touch base on two new things, and Axel, I'll pick on you first, but I'm sure others are out there thinking about this. Molecular profiling. So, you know, we just see $1 billion change hands between a pharmaceutical company and a molecular profiling company a couple days ago. We clearly see more and more movement. Insurance is covering, you know, whether it's genes or proteins, but pan profiling. We're getting back 17-page reports with 150 references, you know, telling us about the mutations that our patients have. Where are we with that? We want to embrace it. How are we going to go there?
Yeah, in some ways, we've already embraced a subset. I mean, we have talked today about MSI tests, we talked about BRAF, we talked about KRAS and NRAS. So it's already in our mindset, and we want to do better. We want to do better, and I think we all agree, at least the hopes there, that in about 5 to 10 years from now, that's going to be our CA. That's going to be our standard marker that we test, not just once, but perhaps even longitudinally with circulating tumor DNA, et cetera, to help us guide our treatment options. Now, at this point in time, we have mentioned this term actionable mutation alterations. Doesn't necessarily need to be a mutation, can be any molecular alteration that could guide decisions. What's really actionable right now, meaning immediate consequences for therapy, is pretty disappointing, at least in colorectal cancer. So it's a lot of wishful thinking, and we all see these reports, and there might be, you know, some of the reports actually give a treatment option based on this, and you look at this and say, really? You know, and whether a PIK3CA mutation always needs an mTOR inhibitor, or a KRAS mutation needs a MEK inhibitor.
Well, Spark is still on these on some of these tests, where pretty clearly that's been shown to be negative, right?
So it's a lot of, let's say, noise right now that's being generated, and I'm a little bit afraid that it leads to overutilization and uncontrolled use of drugs, which I would like to capture what's really going on.
And if we're not responsible about the utilization, we might get burned and not be able to use it maybe down the road.
And there could be real harm. So I think, you know, while it sounds very attractive, wouldn't you want to know? The problem is, you know, the utility of that knowledge is very limited. So there's a cost to these tests, and there's, you know, often imperfect coverage or high copay. The second is, good news, you have an alteration. Bad news, I don't have a trial, and I'm not sure the trial would necessarily always help, of course. Also, I have an off-label treatment which matches it. Well, what's the data that that treatment would help? And all drugs have side effects, including, you know, at the list, risk of death. And there's cost, high copay, and if you think there was a lot of drama getting your Xeloda, you know, sort of covered, getting off-label use, and I think the example for the current class for PI3K mutations, PI3K inhibitors did not work. For RAF mutations in colon cancer, RAF inhibitors, at least as monotherapy, did not seem to work. And I think this means we need to sort of be very cautious around the 5% of patients. We're going through all of this algorithm may actually lead to helping. You need to get the RAS and the RAF testing. Right. The other pieces, I think it's going to take a little time till we figure out what the real utility is.
So we're starting to see some movement and recognition in doing studies that actually then look at the outcomes. You did the test, you made a decision, and then what happened based on that decision. And I think until we have that kind of tracking, we won't really understand the utility of these. And so I'm pleased to see some of that going forward. Last topic.